project that was jointly done between Mackay Hospital and Health Services and James Cook University. And just going to give you a brief outline of actually what we did, what our outcomes were, the lessons we learned, and how we actually evaluated the project. So what we did was we implemented the Adele framework in an aged care setting, and then used the process to train students. So it was an innovative approach to student placements. And probably many of you haven't heard of what the Adele framework is. But the Adele framework is actually a robust risk-managed workforce development tool that's used to establish professional skill sharing and delegation models of care. And what we were interested in doing was looking at what the potential was for students to do professional skill sharing at an undergraduate level. So it was a very exploratory study, and it wasn't looking at trans-professional education, it was looking at trans-professional clinical practice and actually students skill-sharing tasks that were historically the domain of other professions. Just a quick whistle-stop tour of the Adele framework so you can understand what it involves. It's a 7-stage process, and the first stage is awareness raising, which is sort of a process of engaging the staff. Taking a top-down and bottom-up approach, and setting out the why we're actually going to be making changes, getting staff engaged, putting it in the context of what the local and national drivers are. Stage 2 is a service analysis process, which actually focuses on taking a close look at your service and what the potential for change is in the service. And it actually involves looking at every single clinical task that occurs in the service that you're looking at, getting those down on paper, identifying which profession normally does that clinical task and how frequently the clinical task is done. So you end up with quite a comprehensive map of what clinical tasks currently happen within a service. The next step is task analysis. So you go through a risk-managed process with a decision tool to determine what degree of risk is involved in either delegating that clinical task or skill sharing it between professionals, or whether it's a task that needs to remain unidisciplinary. And this is where we put a little bit of a twist on it with this project, because what we actually did in the task analysis process was also consider whether it was a clinical task that could be skill shared between students. So an example of that being maybe a functional mobility assessment carried out by occupational therapists, or shower equipment assessment carried out by physiotherapists. So by the end of the task analysis process, we ended up with 4 piles of tasks, those that could be delegated to allied health assistants, those that could be skill shared between students at an undergraduate level, those that could be professionally skill shared at a postgraduate level, and those clinical tasks that needed to remain unidisciplinary. What you then do is identify which clinical task you're going to train the staff in, find or write competencies or clinical task instructions to make it very explicit and clear exactly what standard you expect of the staff and what processes they have to carry out to successfully complete that task. We then establish supporting systems, which are governance processes, rigorous supervision, communication networks, team meetings, patient allocation processes, to make sure that it's governed properly. And then we embark on training the staff, and then embed processes to sustain the model of care, such as writing induction, having rolling training programs, making sure it's part of the PAD, putting Adele framework into the job descriptions. So I'm not here to tell you and teach you what the Adele framework is, but just really to give you a very brief overview of how we used it in the context of this project. So what we did was we had 2 teams, the community-based rehabilitation team and the transition care programme. And in the time of the project, we had to implement the Adele framework. So do the awareness raising with staff, identify all of the clinical tasks, because Adele only focuses on clinical tasks, not admin tasks, that team does. Take the appropriate tasks through task analysis and determine whether they could be delegated, allocated to students, skill shared, or needed to be unidisciplinary. And then identify or write competencies. We had to write an awful lot, set up a training program, have all the governance processes in place. It was quite a mammoth task, actually. And so we did that in community-based rehab team, which is a service that covers all ages, but predominantly have the older aged population and patients in that service, and the transition care program. So I'm just going to show you what the outcomes were for the service analysis for the community-based rehab team, and you'll see there that we identified 162 clinical tasks that happen in that team. Once they'd identified them through service analysis, we got them to do a time in motion process so that we could quantify exactly how frequently they happened, because you don't want to train students or delegate to allied health assistants tasks that aren't done very frequently. It's not a good return on investment doing that. When we did the task analysis process in CBRT, you'll see that 10 tasks could be delegated, 21 tasks could be allocated to students, and 4 could be skill shared. So we only actually analysed 35 tasks. You wouldn't want to take 162 through the task analysis process. But when something can be delegated, that means it can also be allocated to a student, and it can also be skill shared. And when something can be allocated to a student, it can also be skill shared. So, in terms of what could potentially be skill shared between the qualified practitioners in the team, there would have been 25 of those tasks that we looked at. So the same data for the transition care program. This is a service provided to older people who have been inpatients in the hospital who require ongoing rehabilitation and some degree of nursing care. Different population to the CBRT. CBRT tend to have a slightly more complex caseload, and that's reflected in the outcome here in that a huge proportion of the tasks could actually be delegated to allied health assistants. I do apologise, I just stuck this graph in yesterday and I realised I haven't put the figures in there. That's not very helpful, but the pie chart should give you about 3/4 of the task could be delegated. A small proportion of the tasks, smaller proportion could be allocated to students, and there was only, within that team, there was also an element of tasks that needed to remain unidisciplinary, so there were some slightly more complex tasks happening in that service. So what we did then was, having identified, the staff actually had to train in all of the clinical tasks that we identified that the students would train in. And we actually trained the students in when to stop. So that was actually, they measured the vital signs of patients and determined, whether they were well enough to actually go ahead with any exercise or rehab programs, but also what signs they needed to look for in terms of when they should actually stop what they're doing with a patient. Assessment for the need for a walk belt. Vital signs included pulse oximetry, blood pressure recording, and manual heart rate recording. They were trained in total knee replacement exercises and total hip replacement exercises for the OT students. The OT students were also trained in sit-to-stand assessment and functional mobility, which also included prescription of walking aids. The physio students were trained in shower assessment, which included prescription of equipment, excluding mobile shower equipment, which was determined something that needed to be skill shared and couldn't be passed to a student at this stage. They trained in toilet transfer assessment and equipment prescription, dressing assessment, carer strain index, psychosocial screening, and subjective global assessment and high protein, high energy dietary advice. We intended training them in that. And what we found was we had to drop those two because the actual volume of training that they had in terms of the duration of the placement was just too much. So we've got all the resources ready, the clinical task instructions, but we trained the staff in doing that, but we couldn't train the students. So lessons learnt, really. We had 4 third-year students that we piloted this with and did the training with. They were 2 physio students, 2 OT students. There was a lot of lessons learnt, and what actually happened was we pulled two of the students, one OT, one physio student, were pulled from the project, and 2 completed it, basically because there was a potential that those 2 students might fail their placement, and they really needed to focus on their uni-professional consolidation of those skills. And the reason for those, from what we can determine, were both personal skills. So one was, that the person needed to really work on their communication skills, and that was paramount. At that point, that was the most important thing, and they were at great risk of failing the placement because of needing to consolidate those skills. The other one was around the clinical experience that they'd already had. So the physio we pulled hadn't even done mobility assessment with aids in clinical placements already. He hadn't seen that. So actually then trying to extend him onto OT tasks, he needed to focus on consolidating some of those tasks. The other thing was supervisor commitment. It was a project, a funded project, and we were asking them to do this, and that was a bit of an issue. And one of our supervisors went sick just before the project started, and we had to co-opt and bring in another one really quickly. It was too early for third-year students, we feel. Maybe possible with fourth-year students, not sure. The placement length, physio placements were only 5 weeks, so training them in those clinical tasks, in the theory, letting them model that, then being assessed, but doing it with patients and getting the opportunity to do it with patients themselves leading it, just wasn't enough time. And we wondered whether the taught and modelled components could actually be learnt pre-placement, so the placement is just looking at getting those practical skills consolidated when they're on placement. We are evaluating it. I'll just very briefly mention that we have done a focus group with the students on the 30th of October. On the 12th of November, we're doing a focus group with the student supervisors, and we're asking the question of what the enablers and barriers are to using a skills sharing model of care with undergraduate health practitioner students, digitally recorded and transcribed, and we're going to analyse it for themes, which we're in the process of doing with the first one now. Thank you.